Yeah, like it worked. I still didn't work. I think by the end, I would have just like,
We're not.
you know, all they get from the same like, oh, my gosh, yeah, well, that works cool.
Yeah. This is really no triplets. It's about coming in.
Those are mine. And here you go. Yes. Yes, I remember everything. Yeah.
Yeah.
This is all the same, isn't it? Yeah. Yeah, yeah. I don't want to do that. Trying to be constant. Yeah. Okay.
Dawn was very.
Well, I'm glad. Okay, cool. That's nice. Thanks, Rory. Okay, I think I'm going to get us started. Thanks for joining us today, both in person and virtually. My name is Jen Stead, and I'm the chair of Grand Rounds. Please text in if you're interested in claiming CME credit for today's session. And it's my pleasure today to introduce our speaker, Dr. Alex Taylor, who is a highly regarded primary care physician and pediatrician at the Shoreline Clinic, where he has a broad pediatric practice. He's passionate about high-quality, family-centered care for patients with ADHD and helping them to succeed academically and socially. Those of us who work with Dr. Taylor know him as a thoughtful clinician and a valued colleague who brings both expertise and passion to every interaction. So please join me in welcoming him.
Okay, well, thank you very much for that introduction, Jen, and thanks for having me in family medicine land for Peds. I'm happy to share some of my hopeful pediatric expertise for you. I don't have any big thoughts on adult ADHD, but I have lots of thoughts on pediatric ADHD to share with you today. Hopefully we'll just cover how I go about diagnosing it and how I go about approaching treatment for patients with pediatric age range, so that you can take some of those things into your own practice and pediatric ADHD yourself. I have no interesting financial relationship to anything else to the information that I covered today, or medications I'll talk about today. Here's the things I was hoping to cover. Overall, my goal is to help hopefully all of you feel just a little bit more comfortable bit more confident around pediatric ADHD, going through the process of making a diagnosis, and again, starting treatment for patients when it's appropriate, whether that's medication or behavioral management. Okay. Things that we'll go through in the process are, first, I just want to talk about why would it be worthwhile for you to add and managing ADHD to your practice kids. And then we'll go through defining ADHD, hopefully give a lot of review of things that you have learned many times in your medical education. And then go through at least the process that I use for making that diagnosis, and then arriving at treatment, how to talk about it with families, and then what choices are made for kids in general. So managing ADHD as a primary care provider, I think it is really worthwhile because your long-term relationship with the family is super valuable. Managing this chronic condition that's going to be part of your discussions with the family for probably multiple years. So you probably have found already, even if you have a patient who's managed by someone else, it's hard to escape ADHD coming up in your wellness visits and other visits. Patients are going to have questions about medication refills and things like that. So I think it's great to just be comfortable with it and take more of it on for yourself so that you know what's happening when that comes up. We don't have enough specialists who do this. So developmental pediatricians, psychiatrists who manage this for pediatrics are, always in short supply, and I like to save them for things that are more complicated that we really can't do ourselves. This is not in that category. Knowing the family for a long time will also give you context on what's going on. You'll have a sense, is this something that's totally brand new, and we shouldn't be thinking about a progressive developmental or neurodevelopmental disorder, or is it something that has been a pattern that you've been maybe thinking about over time for a kid, and when they get into school and it's raised as a concern, obviously you're ready to think about ADHD. And then I think it's pretty rewarding to do. It's always super exciting to see a kid flourish, and when you meet a family who's struggling either because of how things are going at home or how things are going in school, and you give them school strategies, you see those patients really regularly, you form a pretty strong relationship with these families, and you see those kids start to catch back up academically. I think in a selfish sense there, it's great to do. Okay, defining ADHD, the DSM-5 diagnosis, persistent pattern of inattention and or hyperactivity, impulsivity that interferes with age-appropriate function, broken up into either inattentive, and you have to have 6 of 9 of the inattentive symptoms as defined in the DSM-5, and hyperactive impulsive, again, you have to have 6 of 9 of those symptoms as defined in the DSM-5, and there's also combined, if you have 6 of 9 of both inattentive and hyperactive, which is not that unusual. They also have to have an impairment. So they should be super hyperactive, but in their context in school, they're thriving, they're getting along well with other kids, they're just super energetic, and maybe it's great to have them in the classroom. That's not really ADHD. It is some negative impact that is showing up in more than one setting. So it's affecting the family, it's affecting their school progress, for example. It's affecting their ability to make friends. A couple other caveats to diagnosing pediatric ADHD: symptoms must be present before age 12. They don't necessarily have to be struggling that much, but to be noted before age 12. Should be present for at least 6 months, those symptoms. It's not just a short-term thing. And you have to take in the child's developmental level. I have a toddler should do well in a 4th grade classroom. And that would just not be an appropriate comparison if we're getting out of his seat at the grade, right? So we have to look at what should a kid be doing before they're teaching.
Yeah, just a little bit for the virtual audience thing, they can't hear that.
Okay, I will do my best to project a little bit more. I just put up a list of what the inattentive symptoms are. We think of those largely as deficits of executive function that kids are struggling with, again, for their developmental age. Just to read a few: missed details, careless mistakes, difficulty sustaining attention in tasks or play, not listening when spoken to directly, frequently doesn't complete tasks. That really is slicing up all sorts of ways that inattention is going to impact a kid's life categories. And again, we want to see at least 6 of those symptoms being quite frequent for kids to make that diagnosis, in this case, of inattentive ADHD. For hyperactive and impulsive, again, 9 symptoms: fidgeting and squirming, out of seat frequently, running around or climbing inappropriately. They're fairly similar to like each other, as you'll probably note. Again, I think to some extent they were trying to get to that like nice 9 number, but we try to get at least 6 of those 9 to make that diagnostic criteria for ADHD. Those hyperactive symptoms tend to be way more obvious in the younger kids. So like you're seeing that even sometimes before elementary school, whereas the inattentive symptoms often come into play like 4th grade and beyond, when kids are asked to do work that takes a little bit more sustained attention, whether it's more reading or just more complicated things like that at that point. So just to be aware of that in your diagnosis, there's going to be a huge variation in what ADHD can look like. Those hyperactive kids, you can probably pick them out sometimes just in your exam room. They're like all over the place. You can't get them to even stay in the exam room for like stay on the table for a 5-minute exam. Like everything has been moved, the drawers opened and things like that. And then there are on the other end with inattentive kids. They may just be sitting there. Maybe their parent like gives them a little elbow to like remind them to answer questions, but that's not unusual in the setting of an exam in general. So it's really hard to like pick that up in the exam room. I think it really takes like the families, what they're noticing over time, and what the teachers are noticing, especially to clue you into those inattentive symptoms a lot of the time. All right. Important to keep in mind that ADHD symptoms can vary in different contexts. So there may be a kid who has very clear ADHD symptoms at home, really causing trouble with the family getting ready in the morning, say. It's impacting their ability to sit in school and do what they need to do, but we get them into a setting where they are motivated, where they get to like burn off some of their energy. Sports is like a classic example, and they're thriving, they're paying attention well in that setting. You'll often hear like hyper focus, not necessarily part of our criteria, but it is something that is a noted phenomenon for kids with ADHD. So they don't have to struggle in every setting. Brief interlude to just talk about some history that I do think is nice to like have in your mind when you're thinking about diagnosing ADHD for a kid. To say that we've been thinking about symptoms like this, like ADHD, for a very long time. Back in 1798, Alexander Crichton, who I think is the founder of UK Pediatrics, described people incapable of attending with constancy to any one object of education. An awful lot like our current descriptions of ADHD. In 1844, there was a German physician who was working with kids, and he prepared this book with kids with multiple interesting behaviors, and one of the characters was Dapple Philip, or literally in English, Fidgety Phil, who in the story struggled to have dinner without knocking things off the table and eventually like upending the table. So people who've been paying attention to what kids are up to for a long time have identified kids who struggle in these areas of ADHD for quite a while. From the treatment history, way back in 1937 was the first described style for the children responding well in terms of ADHD symptom improvement, the use of a stimulant medication. And Ritalin, methylphenidate, that we have today, was developed way back in 1944. This is new to me, named after the inventors, Rita is where we get Ritalin from. I don't know what that says about that relationship. Quick epidemiology is to give you a sense of how often we should be thinking about ADHD or maybe expecting to see it. Estimated prevalence, and this is a wide target, I would say, but at least in the AAP, most recent clinical practice guidelines, they said 7 to 9%. It makes it the most common neurobehavioral disorder in children. Boys are very classic, 2 times as likely to be and they're way more obvious to everyone else around them than those independent symptoms tend to be. Co-occurring conditions are not unusual with ADHD. For boys, I think of oppositional behaviors, conduct disorder. For girls, I think depression, anxiety being fairly common co-occurring conditions. Those can be a little challenging because it's a little bit tough to tease apart. Is this something that just exists alongside of ADHD, or to some extent is anxiety the cause of inattention in the classroom? And that is something to maybe try managing anxiety in that situation and see if those ADHD symptoms improve, or depending on your discussion with the family, try managing ADHD and see if that anxiety improves or needs to be managed separately. Median age of diagnosis is 7 years old, so very young. So what I took from that, a lot of kids probably in that 6 to 7 age range are getting diagnosed, and then much less likely to be diagnosed as we get into middle school and high school age. We'll talk a little bit about why that's more challenging later on. And persistence of some symptoms is common into adulthood. Y'all probably know more about that than I do, but the estimated rate that, again, came from those clinical practice guidelines, 60 to 90% of adults will still have some symptoms of ADHD if they were diagnosed. Right, so move on to talking about diagnosis. This is my process for diagnosis, but I would say most of my patients who end up with an ADHD diagnosis go through. There may be some other approaches, but I think this is often the easiest in the primary care context to make that diagnosis. So most often the families coming to me for the presenting symptoms with raising concerns, often, like last minute in a wellness visit, they're like, oh yes, the teacher said they can never stay in their seat and they're way behind at school. Their teacher says they're pushing in line, it's causing a lot of disruptions in the classroom for them. Their work isn't getting enough time. But the kids themselves are getting frustrated about that. They feel like it's not fair. Other kids are moving on to they're stuck doing maybe the less fun activities. May also be what parents are noting at home. They just note that these kids are always on the go, and maybe you're seeing that in the office too. Often for school age kids, parents will tell me they have to be there sitting right next to them to get them to do their homework, and it takes a very long time. What seems like 30 minutes of homework is taking through the homework. Chores are not are always half done, even playing with activities they enjoy. They do that for a short period of time and then just leave it and move on. That's very classic for ADHD. Sometimes it's really impacting the family's ability to get ready for anything and get going in the morning. Again, take that in the developmental context. I think that's very normal for a toddler. I hope so. And then they also may come more with impact on life for the child than with just the symptoms that we're concerned about. Those are things like the kid doesn't enjoy school. It's a huge red flag for me. This is elementary school in particular I'm thinking of here. Middle school, everyone seems to lose interest. But kids should really be pretty positive about elementary school in general. And if they aren't, I would really think what's going on here. It doesn't have to be ADHD certainly, but it's worth digging into why that's happening. Could it be bullying or something else? Certainly. But please dig into that because that's pretty early for kids to start having a poor relationship with people. Families limiting their activities because they just don't feel like they can do things with their kids because either it's not safe, they're going to run off, or they're embarrassed about the way their child behaves. So that would certainly be something that makes me think about ADHD. Daycare can't handle the child. So obviously, that's a pretty young kid, but daycares are designed to take care of young children. If kids are failing out of multiple daycares, maybe ADHD is one of my diagnostic as well. All right, and then struggling to keep friends as well. These kids are often not on the same wavelength as friends. They maybe sometimes struggle with boundaries as well because of the impulsivity piece. And so that impacts their ability to maintain friendships over time. And some things to keep in your mind when you're hearing those things that sound like ADHD ADHD that we covered on the last two slides. And I break it up to, is there something that's kind of internal to this child, this teen? Are they anxious? Are they having depression right now? That's why they're not engaged, for example. Oppositional behavior, again, fairly classic for boys. These things can definitely be there at the same time as ADHD also. And definitely ask about sleep. If for whatever reason the sleep environment isn't good and they just don't have good sleep hygiene, that can make an impressive difference on a kid's behavior. And certainly think about OSA as well. Similarly, if that's appropriately treated, it can make a massive difference on behavior. And then think about external causes. So things happening around the kid. Are they being bullied at school? So they're not focused on what they're supposed to be doing. Do they have some trauma that, again, is distracting them from learning like the other kids in their class? Is there a language barrier? Just like what they're being taught, just not hitting them in a way that they understand. The material not matched to students' abilities is both are we not giving them work that is commensurate with their level in terms of a kid who is very gifted and he's bored in math because he's doing second grade math and he's ready for fourth grade math and he's acting out as a result? Or is it this kid's developmental level is a little bit delayed for their age, and we're giving them work that they have no capability to understand? That can certainly produce ADHD symptoms as well. And then for your teenagers, certainly think about substance use, particularly if there's something that's kind of coming up that's new. That can certainly impact their ability to be on task. Okay. Screening tool. This is like the most important takeaway from diagnosis. I always use the Vanderbilt. I think it's really great as a screening tool because it both elicits all those 9 inattentive, 9 hyperactive symptoms, and then also tries to elicit a lot of those possible other or co-occurring things on the differential. So there's oppositional questions, conduct disorder questions, anxiety and depression questions. It even tries to get at some of the outcomes. And then there's a teacher version and there's a parent version to start. There are also follow-up versions of both of those. So great way to compare how you're doing after you've maybe arrived at a medication that seems to be working, follow up at least with the teacher version and get their perspective on how well this is actually working for the kid. So if you don't take anything else away and family comes in, they're concerned about ADHD, you don't want to do ADHD management in your clinic, at least give them the Vanderbilt for like a couple for the parent, a couple for teacher, or however many kids, adults are interacting with them in another school setting, and send them off to either a specialist or someone else who does those diagnoses. Okay, that's super helpful. It's really tough when a kid comes in and they're like, we're ready to talk about ADHD today, and then they don't have these, and I'm like, okay, we can't really make that diagnosis today. They're already thought we were at that step, so that's a really frustrating visit if they don't have this information in hand, particularly the teacher form, because otherwise we just can't know what the teacher thinks is going on, and it could be wildly different occasionally from what the parents are reporting. This is a picture of the Vanderbilt, those first 18 questions, because they're pretty much the same on all those versions of the Vanderbilt. If you read a few of them, you'll see that they match up pretty much exactly with what those DSM-5 criteria for inattentive on the first 9 and then hyperactive in the second 9 symptoms. Okay. What we score is the 2s and 3s. So every 2 or 3 is a 1 to add up to 6. Am I saying that in a way that makes sense? For every 2 or 3, you give them 1 point. If you add up to 6 points in the first 9, you've got 6 inattentive symptoms. And if you get enough 2s and 3s in the second 9, then you've got enough hyperactive symptoms. And so those should really be consistent in the parent setting and the teacher setting to meet that diagnosis of ADHD. If the parent thinks they're really struggling, but the school says they're doing really well, I'm certainly going to dig in more into what's going on there, but I'm not going to be diagnosing ADHD. This is on the back of the Vanderbilt. They're like little helpful aid for scoring. I just separated out the sections and labeled what they're getting at here. Inattentive symptoms for the first 9, hyperactive symptoms, together. And then they ask about oppositional behavior quite a bit, conduct disorder, anxiety and depression symptoms, and then again, outcomes that this kid is dealing with. And that section is different for every parent versus teacher and follow-up versus initial. So you really do have to look at the forms, or you can put them into Epic, and Epic will spit out a really nice thing for you that just tells you all of these sections and whether they're meeting criteria or not. Okay, making the diagnosis. So if you talk to the family, they're having negative impacts in multiple settings, and you get these Vanderbilts, they're telling you they've got 6 of 9 inattentive or 6 of 9 hyperactive symptoms or both, that's it. You can make that diagnosis right there. All the recipe for ADHD for this kid, add it to the problem list, and then you can start talking about how to treat it. And feels like maybe it should be a little bit more complicated, and it is probably complicated already. But I really think if you have those pieces, you can make that diagnosis of ADHD. Times when it's more challenging, the really young kids, I already mentioned those toddlers who are not able to stay in daycare. But in general, it's really tough because say what's normal for a toddler as compared to their peers, they're all pretty rambunctious. And so it really has to be way out of the normal to be obvious that a toddler is struggling with some sort of neurobehavioral disorder, possibly ADHD. I think it's tough to pick up in this age group. I am very hesitant before a kid gets into at least kindergarten to really consider the ADHD diagnosis very much. I'm often referring them to a specialist because I worry that it's not just ADHD, that we also have autism at play, diagnosis that I'm assuming most of us are not qualified to make. And so seeing a neurodevelopmental specialist is really helpful for those really young kids who are struggling with these types of behaviors. Teenagers also find challenging. Again, these symptoms should all be present by 12. And so if you have a 16-year-old who you've never discussed this before, and now they're raising issues about their focus, I bring a fair amount of skepticism to that. If they have a very good story that this was considered in the past, they were always noted to have struggled with inattention, but they were getting by, and now the work is more challenging, I'm a little more willing to entertain that. But it's pretty rare that I make that diagnosis in this age group as well, and would certainly consider, again, sending off to a specialist. Seattle Children's Service, the Pearl Clinic, so you can, again, give them Vanderbilts to have completed and send them off to someone who's a little more specialized to make the diagnosis in this age group. Things that I really don't like to hear from teens, I tried someone else's medication and it worked great for me. That doesn't make me feel good about going down this path. In general, I'm worried about your relationship with medications that are controlled already. They're certainly more likely to have other mental health issues that could maybe mimic particularly inattentive symptoms that are more common in this age group. So, and they're anxious, they're depressed, there's something else going on. And so I really want to often address those things definitely first in this age group before I really think about ADHD. And sometimes we'll just say that explicitly. Hey, I really think that this is the biggest piece of what's going on. Let's manage this anxiety in all the ways that we usually do. And if we're still struggling in school, then we'll look at that ADHD piece there. Okay. So then I'm going to jump into how do I approach these kids now that I have made the diagnosis. I'm going to go through what the, again, AAP clinical practice guidelines recommend by age group first. So recommended treatments by age group, how I talk about starting a stimulant with families, and some of the questions that often come up around stimulants, when it's appropriate, how monitoring over time goes with these kids, and then I'll talk about some of the stimulants that I frequently use. I would say it's kind of like steroid medicines. A lot of them work really well, and you just get used to the ones that you use all the time, and you can adjust, play with those. You don't need to know absolutely every stimulant medicine you can treat ADHD. I use a small fraction of what's available regularly. Okay, so preschool age kids, again, not that common to be making the diagnosis. If they do have a diagnosis of ADHD, whether you're making it or someone else is, and they're coming to you to get help with management, the first thing is going to be all about behavior management in this age group. So strategies like setting expectations, creating an environment that's not really noisy and distracting for them. Don't have, at home, like 10 toys available for them to play with, have 2 toys available. So if they're bouncing back and forth between activities, it's not like a crazy situation. There's only a couple things around. Rewards, some evidence that those work pretty well. So like sticker charts, things like that. Checklist, great, because kids often struggle to go through just the daily routine with ADHD. And so all of this can help to keep them on task. There are designed programs for parents. They're not necessarily totally ADHD specific. They're more about managing challenging behavior. But Incredible Years is a great one for ADHD. That's a program that is sort of like franchised and available in many different places. Seattle Children's has their behavior and attention management programs. There's some stuff that is just available online for ADHD management for parents there. They also have regular presentations that are just how to start understanding ADHD with your child. If you are lucky enough to meet it with Pediatrics, you can also connect these families with that for FACT-B, which is, again, a program developed by Seattle Children's to deal specifically with behavior. And then the medication side for this age group is definitely your second thought. If you're going to do one, methylphenidate is generally regarded as where you would start. Less side effects often with that one to some extent. But that would be pretty unusual. And I would again say maybe this kid is seeing a specialist in that situation. Okay, 6 to 12-year-olds, again, this is the most common age that you would see and diagnose a patient. The first recommendation is to start a stimulant. Certainly, the behavior management stuff, like we talked about for the preschoolers, should be done at the same time. Evidence shows kids do better with both together. But the stimulant seems to be the single most impactful thing to do. Okay. So in this age group, I certainly give parents that information, even if they're a little unsure about the concept of treating, just to let them know, hey, this is the thing that we know helps kids with those in this age group manage their ADHD symptoms. Most commonly, I'm using methylphenidate. I think to be generally, like the AAP says, start with methylphenidate. Adderall, also very reasonable to use. And yeah, we'll talk a little bit more about specific medications down a couple ways. For the younger kids, I think in 3rd grade is the separator here. I might do just a short-acting dose, particularly just in the morning. You could add one at lunch as well at school if it seems like they need that to continue functioning well for the whole day. For the older kids, often works well to do a long-acting medicine that they're just going to take in the morning. It's going to get them through the whole school day. For the behavior management at school, I always write a letter when I make this diagnosis to school saying, hey, they meet the criteria for this diagnosis. They would benefit from accommodations and supports as appropriate. I am not particularly prescriptive about what those might be. I think school is probably better at knowing what to implement and being more responsive because they see the kid in that setting. But I want them to know that they should think about that. That's often the cue for a kid to get an IEP or 504 plan to implement some of those behavior management strategies in school if it hasn't happened already. And then there's the 13 years and older group. For this age group, the medication, still first recommendation. We don't have great evidence for other things to do for these kids. Hopefully, we can do some behavior management, some accommodations in school, but the evidence that those help them a lot is much weaker than it is with those younger kids. So if a kid has ADHD and they're really struggling in this age group, stimulants are what I'm talking about the most. most of the time going to use long-acting medications unless side effects wise there's some reason why we probably shouldn't. And I'll just talk about that a little bit down. Yale Children's does have a program supporting teens' autonomy daily, STAN, that is about helping kids develop skills to get through, like grow over time, hopefully in their ability to manage schoolwork with ADHD. So hopefully feeding less medication or at least supporting them while they're on medication. Okay, talking about stimulants with families, some of them are very interested in stimulants. Some of them are quite wary of stimulants, which is careful, reasonable positions for families to come with. I usually try to have a long visit blocked off for when we're going to make this diagnosis, presumably, and talk about stimulants so that we can just go through all the questions and they can feel like they know what we're doing when they walk out of that visit if we're going to start a stimulant. Usually let them know the greatest single evidence for efficacy. One thing you could do is a stimulant in general, again, for those kids who are 6 and above. And the vast majority of kids are going to respond with the first or second medication. 80 to 90% of kids are going to have improvement in their ADHD symptoms, and those outcomes we're watching for ADHD as well. I describe it as stimulants help kids by stimulating the frontal cortex of their brain so that it has more ability to control the impulses coming from the rest of their brain and can help them decide what to focus on in those moments. And try to stress that we're not trying to change the kid. We're just giving them the power to do what they want to do essentially with that stimulant. We're giving their brain the ability to focus on what they want to do in the classroom context. When I'm starting a stimulant, I talk a lot about the process. We're going to start really low, lowest possible effective dose, and we're going to increase slowly. You can do that for pretty much all the stimulants every 1 to 4 weeks. Honestly, on the first day or two, you get a sense of how well that medicine is going to work. Depending on how comfortable the family is, I may say, just send me a message in a week and let me know if you think you want to increase it, or let's follow up in 4 weeks and we'll talk about how the lowest dose went and go up from there. I have to let them know the first dose, probably not the right dose for a lot of kids. Don't be discouraged if you try that out and there's no effects. To some extent, that's great. At least we have no side effects and we can continue to adjust going forward. And along with that, I let them know that if we do frequent visits at the beginning and find something that works, that's way better than not coming in. I see you again in 3 months, you ran out of medication, you're not really sure if it worked or not, then we don't move forward at all. We're probably getting all the side effects associated with medications without getting any of the benefits of sustained attention in the school context that's helping them move forward academically. And I do try to encourage families that what we're really trying to manage is mostly behavior in school with the stimulant medications. This is not something that's trying to make their whole day go perfectly. We want to have behavioral strategies that they're developing at home to help these kids outside of the school context. And in the meantime, the stimulants are helping make sure that school goes well. So try not to let the stimulant use bleed too much into home time in that way. Question?
Do you encourage drug holidays on weekends?
Yeah, I think drug holidays are great. It's certainly family dependent. If the younger kid is unsafe because the bigger kid is impulsive in the family, by all means, maybe you need to use the stimulant every day. But I think a drug holiday is great. There's some thinking that there's a little bit of tolerance that builds up with these medications. And so taking the drug holiday may even help it to work a little bit later or a little bit better when they resume the medication for the next week. Also a great way to manage a lot of the side effects too. Some common misconceptions are just worries that people bring to me about stimulants. One, when you're on it, you're just on it forever. And that is the least true with stimulants. Basically, they wear off every day or after 4 hours if you're doing a short acting, and you could never take it again, and that would be totally fine. So they're super easy to stop. Really try to reassure families about that. And I would say a lot of my families don't discontinue stimulants throughout their whole academic career. It's often, we're doing this for a few years, maybe we're repairing their relationship with school, and then they may not really need it so much anymore. They may find ways to stick with things that gather their interest a little bit better so that inattention is not such a challenge to the schoolwork that they are forced to. Significant long-term effects, I think it's important to be upfront, especially if we're using these medicines for a long period of time and at especially higher doses, there may be a little issue with growth in height. So difference of like 1 to 2 centimeters, pretty similar to like if you're using an inhaled corticosteroid for a long period of time. Dose makes a difference. Drug holidays can help out with that. Otherwise, I don't really think there are significant long-term effects of using these steroids. Substance use is one that people bring up in particular. The evidence definitely does not bear out increased substance use for patients who are using stimulants. There may be some sense that it actually is beneficial and that it reduces rates of substance use for teenagers, say, because they make some less impulsive behaviors. And then there's also this concept that these are a strong medication or that one particular type is a strong medication. I would say they're all dosed makes the difference in pretty much all these medications. So if you are using a very low dose, then I would not think of any of them as particularly strong or harmful medications in that way. And similarly, when you're choosing a medication, I wouldn't worry about choosing one that is lower impact. I would just make sure that you're starting at that lowest reasonable dose for the age of the child. Okay. So this is maybe something that's looked at separately if you're really thinking about using these medications. The common side effects that I talk about when I'm starting appetite suppression, I say I honestly expect it to happen. If a medication is working, you honestly get some appetite suppression. This can be a reason why we stop a stimulant because patients are actually seeing a slowdown in their growth or even weight loss with the level of appetite suppression. It is particularly problematic in the teenager group if patients are kind of interested in the side effects as something that's beneficial. That I always am a little bit cautious around, and it's maybe a reason to think about using a non-stimulant medication. There's lots of ways to manage it. Drug holidays is one. Really encouraging families to take advantage when the kid has normal appetite, make sure they do eat breakfast, and then at the end of the day, when the medication wears off, kids are often ravenous, so take advantage of that and give them their lunch at 3 p.m., say. And sometimes I use nutrition as a resource. If families are really this medication is making things work for this kid, but they're struggling with their weight gain, the nutrition can give them some ways to increase calories in the things that they're eating. I also would consider switching from a long-acting that's working right through their lunch to short-acting that might wear off for lunch when they're hungry, and then they take it again for the afternoon for school, and then have it wear off for dinner, hopefully. Sleep disruption, the other most common side effect. If medication is being used appropriately, it really shouldn't be a big issue, but sometimes, especially the long-acting, it seems like this effect lasts way longer than the benefits, than the increased attention. And so in general, just trying to take that medication earlier, changing to a short-acting is also a good way to reduce that as a side effect. Abdominal pain and headache, I mentioned this because some kids note it just when they're starting. It's usually just the first week and then it goes away. It's usually pretty mild. Just say, push through if it's not a big deal. Irritability, particularly when the medication wears off, is another one that can be challenging. It's kind of like they're crashing off the medicine a little bit. Often it just helps to make sure that's the time when they can maybe be active, so indulge their hyperactivity a little bit, make sure that they do get to eat if being hungry is part of that irritability, or just make sure that that's kind of a restful period in their day. If you're scheduling some screen time, maybe that's the perfect time to just do something that doesn't ask a lot of them. Very rare side effects, sudden cardiac death. The evidence shows that this is probably not related to stimulant medications in large studies. So probably just there is some as there is in the general population, and it is not elevated by stimulants. Hallucinations and psychosis, although very rare, certainly something that I sort of put these all in a box. If they just feel like something is not right, just stop the medication. Again, that's one of the benefits. You can stop after one dose, so you can stop whenever you want without having significant like rebound effects that are worse than where you were at the beginning. General sense that the medication doesn't feel right to the patient. If they come back with that, I always try to get a sense of like what are they meaning? Was this kid like the class clown before, and now they're sitting and doing their work, and it's tough to tease that apart from what our goal is here. Then maybe like negotiate on maybe we need a slightly lower dose, but we're seeing some of the effects we want out of our medication in that situation. Abuse and misuse, I'm mostly worried about this in potential in teenagers. I have not seen it very often, even with quite a few patients being managed for ADHD. And it's certainly a reason to try to manage this with the lowest possible doses and encourage those like break times. So this is not something that the kid is always using. Once you start a medication, you have followed them up every 4 weeks or so while you're adjusting it. You find a dose that they think is working well. Get a teacher follow-up Vanderbilt so that you know that the teacher thinks it's working well also. Maybe they're just not complaining for some other reason. And then you're going to put them into like maintenance, kind of similar to a lot of our other chronic medications. Every 3 to 6 months, I try to do an in-person visit at least every 6 months with these kids, and then it may be every 3 months, like a telemedicine visit, just to talk about how things are going. Even for families who feel like everything's going well, it's not unusual that we end up tweaking something about what they're doing with their medication at those frequent visits. And I think the evidence really shows that being an actively managing these medications while kids are taking them is what makes them continue to be helpful over more time for kids. At the visits, I'm reviewing the growth, make sure they're not losing weight, make sure we're not seeing issues with height as well, checking blood pressure and heart rate, not very commonly abnormal because of stimulants, but worth watching for, addressing the side effects, whatever the family's noticing, of course, and then considering if we need to make a change in the dose. Kids are often, because they run out of medication or because they're doing drug holidays on the weekends, they're often pausing frequently. But I really like to have them try to pause for some amount of time every 6 months to say, hey, do we really need this? Or maybe at least negotiate, we're going to try at a lower dose to see if they really need this medication still going forward. Covered a little bit of that already. Keep moving. A few of the medications that I use frequently, methylphenidate, just plain Ritalin in its short-acting form. Great for especially the younger elementary school kids in the short-acting version. If I'm going to use a long-acting version of that, I often use Concerta. It lasts about 10 to 12 hours, so hopefully at an appropriate dose, it's lasting through the whole school day for kids. They often, either the short-acting or long-acting, take about 30 to 60 minutes to like start to work for kids. So hopefully they take it when they like start heading to school in general. Particular like the long-acting kids often like that because they don't like to go to the nurse and like have to take medication at school. It does often, I think, come with a little more of the side effects as we kind of went through. So in that sense, if you're running into issues, then I often try to move back toward the short-acting medication. Dexmethylphenidate, this one's really valuable for younger kids who cannot swallow pills because the Concerta has to be swallowed whole to be this extended release. But the dexmethylphenidate comes in a capsule and they can open it up and eat that on yogurt or something like that. So that's why I use this one fairly regularly. Unfortunately, all of the medications have their own like scale of what dose is appropriate. So until you're super comfortable, you kind of have to to look it up every time. But again, hopefully you're only trying 1 or 2 medications before you get to what works really well for a kid. Adderall, maybe some sense that in the evidence that people fail off of Adderall a little more often. Maybe side effects are just slightly more prominent in Adderall, so that's why we start with methylphenidate in general. But Adderall also works great if everyone in the family takes Adderall, then I'm a little bit more, okay, we'll just start there. That's totally fine with me. It comes with a tab that they can crush it, and again, have that on yogurt or something like that for a younger kid. The Adderall extended relief lasts them the whole day. That's also a capsule that they can open up, and for kids who don't swallow it, Vyvanse. I feel like this is just another very common long-acting Adderall family extended release medication. No particular reason why I would choose it versus Adderall, honestly, if you're taking this on as your practice. But again, it's the kind of thing where you just learn a few medications and use those fairly frequently. And then if you feel like what you're usually doing isn't working for a patient, definitely start to reconsider that diagnosis as my first thing. Again, like 90% of kids should be responding to a couple of medicines. So if we used a couple things and they haven't helped this kid with the things that they were struggling with, did we make the right diagnosis in the first place? Maybe asking a specialist at that point. And then if they're failing off of a stimulant, not because it didn't work well for them, but because you ran into side effects that are too bothersome, then certainly consider trying a non-stimulant medication. Again, you may want a specialist to help you out at that point if you don't really do this very often, because even I don't have very many kids who use non-stimulants for management of ADHD. But the 2 main types are alpha-2 adrenergic agonists, guanfacine and clonidine, which, especially for the younger kids, seem to work well when like hyperactive behaviors are the biggest challenge. Sometimes you use those at the same time as ADHD. They're focused, but they still like are out of their seat. If you use them at the same time as a stimulant medicine, so they're focused, but they're still out of their seat a lot. And so the guanfacine or clonidine can help in that situation. And then atomoxetine, somewhat similar to the stimulants, but doesn't have the significant similar side effects, like the appetite suppression in particular. Probably the last thing I'm reaching for. Doing it, I'm often referring to the specialist at the same time, because I feel like my chance of being successful here is fairly low. I think that just wanted to go back to why you should do this as a PCP. Again, you're going to run into it if your patients have ADHD, no matter what you do. You can't always get help from the specialist for this. Again, I think it's something that's surprisingly easy to like get your arms around and super rewarding to really help out by managing ADHD. Question?
Thanks, Alice. This is really helpful. Couple questions from the virtual audience. One was, any suggestions for referrals to psychiatry with those concerns of comorbidity, particularly autism, especially for Medicaid or unusual insurance, that Seattle Children's have a long wait?
Yeah. So within UW, if a patient is young, so you're thinking that preschool age range, Dr. Liz Snappin in the Fremont Clinic does autism evaluations. So if you're really thinking that's a big piece, that I think it's great to send them to her, because that'll happen a lot faster than it would through Seattle Children's. Other than that, it is hard. Yeah, to like find those resources. There is separately like neurodevelopment at Children's. If you don't think there's any big issue, but you feel like this behavior is abnormal, then you can have them see the neurodevelopment clinic at Seattle Children's. Up at Shoreline, we have child psychiatry, so I use that, but not really available everywhere through our BF program. So that's been a nice resource for us. But finding a psychiatrist, child psychiatrist, is often a good way who's accessible to you. It's often a good way to get this evaluated too.
Also, how and where to refer for behavioral therapy.
So Seattle Children's has, I usually refer into our like social work team through our clinic, and they connect the patients to Seattle Children's resources. So they have super parenting classes, which I think are for even kids below 5. They call it Incredible Years, but they have a program for parents for kids between 5 and 15 as well for behavior difficulties. So you can also just put in a psych referral, but Seattle Children's, and then indicate that that's what you're looking to connect parents with, and they should connect them. And then those exist elsewhere. So Mary Bridge does Incredible Years. So an option.
More virtual questions.
Actually, Jen, can I ask Alex a follow-up question?
Oh,
real quick?
yeah.
Yeah, so for those programs, are they pretty accessible to parents to get kids in or get parent families in pretty quickly? Or I don't know how long their waits are.
Yeah, I would say it's on the order of months, but not years. Yeah, and I know like it's definitely something that feels immediate because the kid is struggling in school a lot of the time. But I like those are skills for a lifetime. So I think like waiting 3 months to get into a class is like not terrible. Yeah, you can take that perspective at least.
Another question was, what if there's some height filtering and evaluating that? Is it reasonable to try a non-stimulant first? Or going stimulants?
Because you're worried that this kid is already very short. Yeah. I honestly probably wouldn't. I would, if you think the height is a problem, I would evaluate that separately, certainly. But I wouldn't, and I would watch the height very closely if the kid is already on the short side. But you know, unless they're professional soccer player potential, like I'm not too worried that we're taking that like 1 to 2 centimeters from their growth. Yeah, so I would probably go with the stimulant because it's way more likely to work well for them. And then be mindful of maybe drug holidays so that their overall amount of medication is lower.
One more question from virtual audience is, while there's good data on short-term outcomes for medicine, the data for long-term outcomes show mixed or no improvement in overall outcomes. What do you tell parents about this?
Yeah, partially, I tell them that my goal is not that they are going to be, so there's kind of like 2 parts, I think, in that question. One, I tell them that medication is not something that I'm planning for their child to be on forever. So hopefully this is like we're repairing their relationship with school, and then they can function well without needing medication, or at least needing medication much more sparingly in the future for settings where their attention is particularly challenged. And I always try to feel like I am managing based on what is going to improve quality of life right now, because that long-term data, it's hard to know what to make of it. That the fact that we have treated these kids and you see them benefit so much in the elementary school age, and then maybe it doesn't make a difference for them as an adult in the outcomes that are measured in those studies. It's hard to say, like, with the alternative, I guess I'm not going to do anything to help you right now, and that also doesn't feel like it works well for the whole family. So I try to be mindful that ADHD, they're likely to have those symptoms going long term. I don't think any of us has an answer quite to that question yet. I think that data is also fairly like new from the big like long-term studies, long-term study follow-up. So I think also like the whole field is struggling with that. Yeah. So if that was a satisfactory answer to that question.
Yeah.
But, yeah, it certainly hasn't changed what the like clinical practice guidelines are.
Any other last questions?
In adult onset ADHD, oftentimes, in my practice, I like to try a non-stimulant versus like Wellbutrin. Do you know if that's gonna be coming down the pike for pediatric medicine as well?
So I do sometimes use those in like my teenage patients who are also endorsing some of those symptoms. Maybe I'm not even diagnosing ADHD, but I'm treating them for depression, and I'm going to use Wellbutrin as my first choice because they're struggling with those symptoms. I do not think that it is going to, like, for that 6 to 12 age group, I don't think we're going to see like using Wellbutrin. I would be much more worried about the side effects of that to some extent, and like the difficulty with having an impact relative to the stimulants, where the family, the teacher, the kid often themselves see the impact right away with the stimulant medication. So I think you're probably going to do much better with both outcomes and compliance with stimulants.
Well, thank you, Alex.
Please remember to fill out the survey, and Grand Rounds will be on a break in August and we'll resume back in September. So thanks for joining us today.
Thank you.